when we do a forest plot of coronary heart disease deaths and total fat, again we find that this sits on the line of no effect, and therefore there is no difference between the coronary heart disease deaths for the higher fat intakes and those with the lower fat intakes. And again, examining coronary heart disease deaths and saturated fat risk ratios, it sits on the line of no effect, so we cannot say that there is an association with the pooled evidence that we are able to examine between coronary heart disease deaths and saturated fat. So in summary of the epidemiological evidence available now, we have 7 prospective cohort studies able to be evaluated, covering almost 90,000 participants, 94% of which were male, and all but one excluded previous coronary heart disease. That particular study could not be used in meta-analysis because it did not have data conducive to that. None examined the dietary guidelines. Again, I would not expect them to, and there was no significant difference for total fat, no significant difference for saturated fat. The one study that looked at cholesterol found a relationship between the baseline cholesterol and subsequent coronary heart disease mortality in younger people, but not older people. Again, that's an association, it does not mean causation. So the conclusion of the 4th part of a 4-part thesis examination of dietary fat guidelines was that epidemiological evidence currently available also does not support current dietary fat guidelines.
Now, Dr. Harcombe, were there any other meta-analyses that were performed in respect of the dietary guidelines and the evidential basis for them?
Absolutely. At this point in the thesis, it's very important to look at other meta-analyses that have been done by other researchers. The decision to examine the dietary guidelines as were available to the dietary committees was original and had not been done before. But a number of other researchers have examined either prospective cohort studies and randomized controlled trials, or just one of those, or both. So for example, we have Skiaf and Miller from 2009. By examining 28 studies, 280,000 people, just prospective cohort studies, just looking at total fat and coronary heart disease mortality and events, they also found no significant difference, no significant difference. Siri Torino, looking at prospective cohort studies, almost 350,000 people, no significant difference, no significant difference. We'll come back to this significant difference in the Mozaffarian 2010 study. And then we turn to the Hooper, the first of 2 studies that the pro forma complainant wished to put into evidence last Tuesday.
Dr. Harcombe, are those the Cochrane reviews?
They are indeed, sir. So there was a Cochrane review undertaken by Hooper in 2011, and then this was repeated in 2015. So there was actually no need to put that paper into discovery. I am, of course, very, very familiar with that paper, as would be any researcher practicing in this area. So the 2011 study looked at 21 studies of 72,000 people. And for total mortality, looking at all randomized controlled trials, it found no significant difference. For modified fat, total mortality, no significant difference. For reduced fat, total mortality, no significant difference. And for reduced or modified fat, no significant difference. It then moved on to cardiovascular disease mortality. Looking at all RCTs, no significant difference. Modified fat, no significant difference. Reduced fat, no significant difference. Reduced and modified fat, no significant difference. So it moved to cardiovascular disease events, and I will return to that conclusion. Modified fat, reduced and modified, no significant difference. So 11 out of 12 of the results of the Cochrane review in 2011 found no significant difference between anything that they looked at and cardiovascular disease mortality or total all-cause mortality. The Chowdhury study from 2014 found one significant difference. I'm going to pull out these 4 significant differences and explain them at the end. But it also found no significant difference with saturated fat or monounsaturated fat or polyunsaturated fat. A number of people have looked at a number of different things, but the overwhelming conclusion is that we are not finding differences when we are examining total fat or saturated fat. I won't take you through all of those, but Schwinkelschak and Hoffman from 2014 also found no significant difference in every single element of mortality or events that they examined. My study, at the time, this was the only one that had been peer-reviewed, and I didn't exaggerate this table by putting in all of my findings. I've just put the first findings from the RCTs, and of course I found no significant difference in that first paper. I could have added 6 more lines, but I'll be as fair as possible.
Now, Dr. Hooper, a lot has been said about the Hooper study. Would you like to comment more significantly in respect of that?
Well, absolutely. So here we have the Hooper 2015 study, and at the very opening of the Hooper 2015 study, they report why they felt the need to undertake that study. So on the opening page it says, why is it important to do this review? And it says that public health dietary advice on prevention of cardiovascular disease has changed over time, with a focus on fat modification during the 1960s and fat reduction during the 1990s. Following the introduction of US and UK dietary guidelines on fat reduction, limiting saturated fat intake to 10% of energy, brackets, Harcombe, 2015. So it is quite possible that our paper from February 2015 prompted the Hooper review of the 2011 study. So when they did this review, this time they looked at 8 different factors, and they found no significant difference in 7. And again, they found this one isolated CVD events, cardiovascular disease events, one significant difference. And this significant difference, just to put it in perspective, that is a relative risk of 0.83. So what is important is then to go to the paper and to look at the absolute risk, because relative risk is meaningless unless we know what it actually means for humans. So I looked at the paper, and for cardiovascular disease events, there were 4,377 events among 53,300 people over a period of 52 months. That works out at an annual absolute risk of 1.91%. If you then, as you should, apply the 17% to that absolute risk, the higher level becomes 2.06% and the lower level becomes 1.76%. So what that would absolutely mean is slightly more than 2 people in 100 or slightly fewer than 2 people in 100. And that's what that event data comes down to. Now, I mean...
Is that a statistically significant difference?
Well, there's a statistically significant difference on the relative risk, but then the absolute risk is just an absolute examination of that relative risk. So it's just stating a fact that it would be slightly more than 2 people in 100 or slightly fewer than 2 people in 100. But the other point, and I'm indebted to Dr. Trudy Deakin for this next point, who is an enlightened dietitian in the UK. And Dr. Trudy Deakin noticed, we both examined the paper in great detail, Dr. Trudy Deakin noticed that because in this particular number, when you present a number that is statistically significant, you should report a statistical term called I-squared. And I-squared is telling you, have you observed a difference in true effects? Was this a real difference that you've observed? Or could it be that the studies were so different, you've had a muddying of the waters in effect? So you look at the studies alone that contributed to that conclusion, and you run a sensitivity analysis. And Dr. Deakin noticed, and it's on table 8, page 121 of the Hooper 2015 study that was kindly admitted into evidence for the panel last Tuesday, so you have the full report. Dr. Deakin noticed that when the sensitivity analysis was run, it did not stay significant. So that one significant difference found in a Cochrane study disappeared when the sensitivity analysis was run. Now, as a researcher in this area, I think that the Cochrane report should have reported how many of their findings were not significant, because that is as important, if not more important, than what is significant, because it tells us what we do not need to worry about. And we do not need to worry about mortality, all-cause cardiovascular disease, coronary heart disease, myocardial infarctions. We do not need to worry about those. It's this one event number that they came up with, and they should have reported in the abstract that when they tested that number for the sensitivity analysis, that significance disappeared. So we have 35 out of 39 results from other meta-analyses that have said there were no significant results. Of the 4 significant results that we ended up with, the Chowdhury one I agree with and would be universally agreed with. Trans fats are not fit for human consumption. We've discussed the 2 Hooper trials, that essentially the one event data disappears when subjected to sensitivity analysis, and that is in their own paper. The final one to address is this 2010 result from Mozaffarian. Mozaffarian included the Finnish mental hospital study, which is not randomised and not controlled. They should not have done that. And they excluded the Woodhill and the Rose corn oil trials, as they would not have been favourable to their outcome. And the reason I'm so familiar with that paper is reference 43, working with Ufi Ravenskoff and other researchers, we put in a rebuttal to that paper, which was published in the Mayo Clinic Proceedings, pointing out the flaws in that study. So in totality, I have found no evidence, and no other researcher has found any robust evidence to support those 2 dietary fat guidelines. This is how it was presented by Hooper. The findings are suggestive of a small but potentially important reduction in cardiovascular risk, and then repeated in 2015. They went slightly further. Small but potentially important reduction in cardiovascular risk. Replacing the energy from saturated fat with polyunsaturated fat appears to be useful, but replacement with monounsaturated fat unclear, and replacement with carbohydrate less useful. I suggest less useful is academic speak for don't replace saturated fat with carbohydrate. But of course, as we've seen, that is based on data that fell away with sensitivity analysis. So in total, because Hooper was seen as so significant, being the one exception in the literature, 11 out of 12 non-significant, 7 out of 8 non-significant, nothing significant for all of those factors, all of those types of all-cause mortality or incidents. In the conclusion that puffer, polyunsaturated fats, may be a useful replacement strategy, on examination of the 11 studies included in that conclusion, only one study actually did replace polyunsaturated fats in and saturated fats out. And that was the Dayton LA Veterans Study, which of course concluded this is not a good idea. Why was this so different to other reviews? Why did it even find one significant finding? Well, the Hooper study was the only study to include 4 studies that none of the other researchers included. And those 4 studies totaled 646 people, and they were not about cardiovascular disease or coronary heart disease. One was about skin cancer, one was about diabetes, one was about hypercholesterolemia, and one was about glucose intolerance. And I wrote to Dr. Hooper about some of these studies, and she replied, most of our mortality and cardiovascular disease event data followed contact with study authors. So this is why they don't necessarily tally with published data. Much of our data were not published at all. And by not published at all, that also therefore means not peer-reviewed. So Hooper has written to the authors of those studies to ask, did you by any chance have heart disease data that could accompany your investigations into those other factors? And they did, and they presented them to her. So only by including that data could the CVD event statistic be established, and as we've just seen, even though it were established, it was not robust. It did not hold up to scrutiny. The one final point on that page, even if that 0.83 result had stood up to scrutiny, because it included 11 studies, not one of which was undertaken on healthy people of both genders, the results would also not have been generalisable. We could not take that 0.83 and apply it to whole populations because it did not study whole populations. But we don't need to rely on that fact because the data were not robust. This summary table was put in for the convenience of the panel attached to my curriculum vitae, and it just summarised looking at the RCTs then, the RCTs now, the epidemiological evidence then, and the epidemiological evidence now, which of them tested the dietary fat guidelines. None. The people that they studied, very few men, a large number, or larger number, mostly women, a medium number, entirely men, and then a large number, mostly men. And did any of them find in favour of either of those guidelines? No significant difference in all-cause mortality, no significant difference in coronary heart disease and mortality. None implicated total fat, one suggested an association with saturated fat, and again, no significant difference. And even had any of those results been significant, none of those results were generalisable. And Hooper did also say that the evidence is of weak quality. The evidence is poor, and it did not find in favour of those dietary guidelines.
So, Dr. Harcombe, having looked at the research that informed the dietary guidelines and having indicated to Madam Chair that they don't seem to be evidence-based, certainly not evidence-based, what's the consequences of that?
Well, in the final chapter of a thesis, one should look at all the evidence that's been put together and examine what the consequences should be. And I thought it was interesting to go to the dietary guidelines at the time to see if they had any concerns. And it was expressed in the first edition of the dietary guidelines by Hegsted, Mark Hegsted, who was instrumental in establishing those guidelines. There will undoubtedly be many people who will say we have not proven our point. And a number of senators who wrote a piece within the second edition, they noted a lack of consensus among nutritional scientists and other health professionals. And then the narrative in the edition said, some witnesses have claimed that physical harm could result from the dietary modifications recommended in this report. But the committee answered its own concern by saying the select committee finds that no physical or mental harm could result from the dietary guidelines recommended for the general public. So they foresaw no concern setting a total fat limit of 30% and inevitably therefore making carbohydrate 55% of the diet, despite the fact that a 55% carbohydrate diet had never and has never been tested on any population. Now this is the UK graph. On the next slide we have the US graph, and we look at obesity rates as they've increased across the world. So since the dietary guidelines were introduced in the UK around this point, and obesity rates in the UK in 1972 for both men and women were 2.7%. And by the end of the last century, for men they were 22.6%, and for women they were 25.8%. So the UK experienced an almost tenfold increase in obesity during the final quarter of the last century.